morning. Grab your coffee. This is Morning Pulse, where we talk about what's happening in hospital medicine. I'm Lisa. Today, we're going to talk about a problem that tends to get pinned on the emergency department, but mostly involves hospital medicine. It's called boarding. Chances are, right now in your emergency department, there are patients waiting on a bed upstairs. So let me ask you, when this happens, does this end up being your problem to fix? For most of hospital medicine groups, it does. And it's not new. The hospitals have been leaning on their programs to help relieve the boarding problems for a better part of 2 decades. It tends to get framed as maybe an ED capacity problem, but most of the levers that help relieve boarding issues remains with hospital medicine. So it's either a real burden or a real opportunity. Now, I'd argue it's the second. Let's get into it. How big is this problem? It's a real problem. Emergency room physicians have reported that about 90% of the emergency departments deal with this crowding on a routine basis. And the American College of Emergency Physicians has called it a public health crisis. Why it matters beyond crowding itself comes down to 2 things. The first one is safety. Around 70 studies now link boarding in the emergency room to delays in treatment and worse patient outcomes, including higher mortality. And then there's the cost. A 2024 study found that ED boarding has nearly doubled the daily cost of care. And here's the piece that makes it ours, hospital medicine. The root cause isn't really in the emergency department. It's hospital-wide throughput. How fast are the beds upstairs turning over? When do the discharges really happen? This is why fixes in the ED itself don't often move the needle, and it's the throughput where actually hospital medicine lives. What a hospital medicine group can do actually starts before the admission even occurs. And it's a leadership job. We need to coach our team to honestly evaluate each patient and determine, do they actually need admission as an inpatient, or can they be managed safely at a lower level of care, whether that be observation, home with services, or even a direct SNF placement if certain criteria are met. Every avoidable admission will open up that ED bed. It's right sitting, not turning people away. And then for the ones that are admitted, we need to flag a target discharge date and that discharge criteria on day 1, and work that into your morning multidisciplinary rounds every day. Treat the discharge before noon as a process. So maybe write conditional discharge orders the night before. Engage with case management on admission for anybody who's clearly going to need a skilled nursing or acute rehab bed. A more distinctive move, and one that most groups haven't made, is maybe putting a hospitalist on a bed management assignment. So instead of a patient rounding shift, we have one hospitalist who owns real-time capacity rounding in the ED and the ICUs, deciding which unit those admissions really belong to or should be admitted to. Johns Hopkins actually tested this out, and they saw when they implemented this, their ED throughput dropped about 98 minutes. Their ambulance diversion also fell, while they still actually saw 9% more patients. Now, and clearly an obvious caveat to this is that this is for a very large group. Staffing a medical director around the clock obviously would add more FTEs. So you'd want to be well past maybe that 27 FTE group. But for a very large group, this is a very high leverage thing we could implement. Where I'd have a group start is 2 places. First thing, tomorrow, use the multidisciplinary rounds that you already have to drive discharges. Don't just review your patient list, but discuss discharges. Make it a point every day. And then, of course, this bigger one would be to maybe pilot this hospitalist bed director role, maybe if just for a few shifts a week, or even just during admission surge times, and see if that improves your ED throughput. Well, that's the pulse for today. ED boarding gets framed as somebody else's problem, but it is one of the clearest places that hospital medicine can show what it's worth. We'd love to hear how your group is approaching it. So drop it in the comments and I'll see you next time.